Hello, good evening, everyone. Today we will going to start our Harrison-based discussion further with a new topic that is headache. Now you all know headache is the most common symptom that you ever will encounter in your OPD, on your relatives or your any friends. The most common symptom that everyone is having that is headache. Now, what happens with headache is that our understanding in UG level is also not that much good about headache when we are doing MBBS. Also in PG, a little bit we get to know about headache. But headache carry a symptomatic approach. Matlab, there should be a symptomatic approach and a clinical based history taking should be there so that we can diagnose and we can correctly treat the headache. Because sometimes headache from someone can be a condition in which his day-to-day life problems can be there. So in PG also sometimes we don't see headache patient too much. So what I guess that after we complete this lecture, we will get a clinical orientation about the headache. And according to me, when I was also doing UG, I was also not having that much how to handle a patient of headache, how to see. So with me, this happened when I was in GB Pant, I was in my neuro posse. So there are some OPDs like headache OPDs were there. In we used to see around 100, 200 patients on a single day. So when you see lot of patient of related to headache, then you get a little bit of approach that how should you approach the headache because it is not that much as easy symptom that we think and generally now we don't get that much of case also in UG and PG level. So we will start with headache and I will like everyone to give me thumbs up if they know any one of their nearby who are suffering from headache. Now this headache problem is so much common. Like you can see that the big celebrity like Sunil Shetty, he is suffering from migraine. And you all know that Salman Khan is suffering from trigeminal neuralgia. So, so now you can know the how much headache is common in every society. If you are poor, if you are rich, you are anyone. But headache is common in all society. So you should know how to tackle headache because day by day you are getting one or two or three patients every day who is having headache as a symptom. So before we proceed with headache, we will first know what are the pain sensitive structures in our cranial. That is our intracranial and extracranial. Okay. So starting with our pain sensitive structure, which are intracranial, they are dural venous sinus, then are dural arteries, then are your large veins, then are your dura around blood vessel, then there are arteries of circle of Willis, then are initial few centimeter of medium sized vessel, and the in the last is your pia mater and small cerebral vessel, which are the newest one to add in this. Can any one of you tell me the pain insensitive structure in intracranial? Anyone who know what are the pain insensitive structures in intracranial? Because this is the MCQ which generally we ask. No one. So I will tell you the pain in sensitive structure, and that is your ventricular appendage and your choroid plexus. Okay, these are your pain insensitive structures in your brain. Okay, now what are pain sensitive structures in extracranial? That is your skin, that is your scalp, that is your cutaneous nerve, that is your periosteum, that is your neck muscle, that is your cervical nerve root, a mucus of sinus, then it is your teeth. Now, what we have found that all the pain sensitive structure are supplied mainly by one nerve, that is your trigeminal nerve. Okay, and some structure are supplied by your upper cervical nerve. And what is your pain release center? That is your spinal nucleus of fifth nerve. Shall we proceed further? Now, before we proceed further, we will also see what are the key structures involved in primary headache. So, the large intracranial vessels and dura mater and the peripheral terminal trigeminal nerve innervate this structure. So, all the structures, the pain sensitive structures of your cranial are innervated by trigeminal nerve. Okay. And the caudal portion of the trigeminal nucleus, because we are having a trigeminal nucleus which extends into a dorsal horn of upper cervical spinal cord. So trigeminal nucleus from your brain stem is extending towards your upper cervical cord also. And there is central rostral pain processing regions such as ventral-posterior medial thalamus and the cortex. And there are your some pain modulatory systems in the brain also processing your pain pathway with the help of trigeminal nociceptors. Now, we will begin with the types of headache. So, what are the types of headache? We will start with. Now, these are your primary headache, then is your secondary headache. Can any one of you tell me the most common or any cause of secondary headache? Anyone? If you do, common cause of secondary headache. So, starting with primary headache. In this condition, headache is itself a disorder. And in secondary headache, headache is due to and Krish has told that is acute infection. Yes, no, primary headache is a headache in which headache is itself a disorder. But secondary headache is like due to suppose you are having dengue, and because of dengue you are having headache. That is secondary headache. Because of meningitis, if you are having headache, that is your secondary headache. But in primary headache, headache itself is a disorder. So in primary headache you have to treat headache, but in secondary headache you have to treat that systematic condition which is leading to headache. Good and Krish. So headache is due to exogenous cause. And what are these exogenous cause? Like he has said, that are infection, that can be any kind of tumor, any systemic disease. And primary headache are generally benign, they are recurrent. Why are they recurrent? Because in this, the headache itself is a disorder. And there is no organic cause. So now we'll proceed further. Now, what are the common causes of headache? What we see? Now, in this table, what we are seeing that most common cause of primary headache is your tension type headache that encounters about 69%. Then comes migraine, which is around 16%. Then there are some idiopathic stabbing, exhaustion, and cluster. When it comes to secondary headache, most common is your systemic infection, which encounters about 63%. Then is your head injury. Then, and last but not least is your brain tumor, which encounters about 0.1%. So what generally when we worry about headache, we think that it's a brain tumor or maybe it's a brain tumor. So what we are seeing that secondary headache, the brain tumors accounts only 0.1%. But what I will say you that sometimes when patient come to us now about headache, he is like, sir, headache बहुत दिनों से हो रहा है, कुछ समझ नहीं आ रहा, and you will try to say that maybe you're suffering from migraine, maybe you're suffering from another thing, but he thinks in your mind that maybe he or she may not be having any organic disease. So you always, for the safe and for the sake of patient, always do imaging like MRI, CT to rule out everything. Because when you rule out anything, na everything, so patient also think like that. Okay, I am not having any organic cause. My problem is only primary. So that anxiety will be settled, and that anxiety stress will lead to some decrement in headache also. So always do every kind of investigation which patient want, because the anxiety and the distress will also lead to some kind of stress factor and will lead to headache. So always do imaging to rule out every kind of thing. Now, before we move further, we will see some red flag signs. And I guess every one of you are knowing what about red flag signs. Like someone say ना कि बॉयफ्रेंड नहीं बनाना, इसको रेड फ्लैग है, ये गर्लफ्रेंड नहीं बनानी, इसको रेड फ्लैग है ना? So how many of you are knowing what are red flag signs? Can you tell me? So what are these red flag signs? Now these red flag signs help us to distinguish between primary and secondary headache. Now, so all of you know that if someone your friend is saying that यार उस लड़की को मत पटा क्योंकि रेड फ्लैग है वो लड़की. What this means? Some danger signs are there. That's why you are not approaching that girl. Okay. So same here is for headache. There are some red flag signs. If you see these red flag signs, you should always suspect that there is some secondary cause and you need further investigation. So, what are these red flag signs? These red flag signs will help us to distinguish between a primary headache and secondary headache, and will tell us that we should investigate more or not, or we should keep everything normal and we should treat this patient as a primary headache. So, what all are the red flag signs? One is a sudden onset headache. Then is your first severe headache. Then worst headache ever of your life, which happens in or subarachnoid hemorrhage. Okay, vomiting that precedes headache, and subacute worsening over days over weeks. Any pain which is induced by bending, lifting, and coughing. Pain that disturbs your sleep or presents immediately upon awakening. Suppose you are getting headache and you are not getting sleep. So you are sleeping and suddenly you wake up due to your headache. That is your red flag. Any systemic illness like any meningitis, any infection, any dengue, any malaria. Headache onset after age 55. Because when headache is after age 55, it generally implies that either it can be a temporal arteritis, which is seen in giant cell arteritis like of patient, or it can be any IC bleed, fever, or unexplained systemic signs. Abnormal neurological examination. Suppose you are finding any focal neurological deficit, because in patient like primary headache where there are condition like TTH, migraine, you will not find any FND like focal neurological deficit. But if you are finding any focal neurological deficit, then you always think in terms of your secondary headache. Then comes pain associated with any local tenderness. Because if you are having pain due to temporal arteritis headache, so you will have pain or pain near your temporal arteritis distribution area. After that, now we will proceed to the most common primary headache. The most common primary headache, that is your TTH. So, can any one of you tell me the most easy and most common way to differentiate between TTH and migraine? If someone said that this is that it is short as TTH, then, or if it's not, then it is migraine. Anyone? The most common way to differentiate between TTH and migraine. So, by this diagram, you can know the most common way. The most common way is TTH is always bilateral, whereas migraine is always unilateral. Later on, migraine from unilateral can progress to bilateral, but it always start as a unilateral type of headache. So, in tension type of headache, you are seeing this band. So, this pain is like that someone is constricting your head by a band. You have seen us when when some patient is having headache, is like कि चुन्नी बांध लेगा सिर पे एकदम ऐसे बैंड की तरह, क्योंकि pain of tension type headache is like a band like of pain, band sensation that someone is constricting your head from both the sides. So we will start with tension type headache. It is most common type of primary headache, more common in females than males, generally between 30 to 50 years of age. So what we have seen that maximum primary headaches are more common in female than in male, and especially in between 30 to 50 years. That is your working class. So why this happen? Because we all know that female generally do more kinds of work. They have to handle office, they have to handle their home, so they have to do multitasking. And if you are doing multitasking, then this will happen and this will create stress. So I guess you always should respect female in the way that they handle lot of work, no, which a male can't handle many times. So that's why female are suffering from so much of headache. So I will also say to you that if you are suffering from any kind of stress, let it go. If you hold it or if you are doing something which you don't like, it will create stress and it will trigger a headache. So don't do like this. If thing is going with you, then you must do it. And if you're not, then you should avoid it. Any one of you, if have you ever suffered with tension type headache or migraine, then just reply me. So it is related to stress. So that is Ankesh, he is saying he's having tension type headache once he has suffered. So what I will say to you that please यार stress नहीं लेना, है ना भाई, लाइफ में स्ट्रेस नहीं लेना, कुछ भी लेना है औरों को स्ट्रेस दो चलेगा, बट खुद कभी स्ट्रेस नहीं लेना लाइफ के अंदर। होती है तो होएगी, नहीं होगी तो नहीं होगी। और स्ट्रेस लेना भी है तो बड़ी चीज का लेना है, छोटी मोटी चीज का स्ट्रेस लेके कोई फायदा नहीं है। छोटी चीज का स्ट्रेस लेके भी वो कंपनी करेगी, बड़ी चीज का स्ट्रेस लेके कंपनी करेगी, तो स्ट्रेस बड़ी चीज का ले ले, कुछ फायदा ही हो जाएगा। छोटी चीज से तो बेटर मुझे लगता है यही है। तो अगर काम होता है तो करेंगे, और मल्टीटास्किंग नहीं करेंगे यार, मल्टीटास्किंग कभी नहीं करनी। अगर नहीं हो रहा तो स्ट्रेट अवे से नो टू एनी। इफ यू कैन हैंडल दैट वर्क, डू इट। इफ यू कैन नॉट हैंडल, stop it, don't do that work. I think this should be the approach now for doing anything in life, because many times what is the main factor of stress, that you are doing something which you don't like. So don't do any kind of thing which you're liking. Okay, Ankush, maybe this will help you and relieve your stress. So it is related to stress and depression. So it is like fullness, tightness, or pressure, a band like. And one of the more important factors is that it doesn't affect your daily activities. Like in migraine, it affects your daily life activities. But generally, you see, now maximum patient, if they are having headache, they take one tablet of paracetamol and they are doing their work. That is your TTA. It doesn't affect your daily activities. And what is your drug of choice for acute attack? It is your NSAIDs, or you can take your a tablet of paracetamol. And for chronic TTH, drug of choice is amitriptyline, or maybe in market comes with triptomar. So now suppose there is a patient, suppose they and who's having who has experienced TTH in his life. Suppose any patient is coming in your OPD and he's like, sir, whenever I am doing more work. I am getting this tension type of headache. This is a band like of headache. What to do? He is giving multiple episodes, like 4 to 5 episodes he is getting. And you have taken proper history. You are also here is a TTS type of headache. So first, what you will prescribe? Suppose any patient can, you will prescribe him a tablet PCM 1000 mg or maybe 500 mg, depending on the severity. SOS. Matlab, whenever there is headache. After that, if you are thinking that this headache has converted into a chronic TTS, then you will prescribe him a tablet, amitriptyline, and you will start with a low dose initially. That is your 10 mg HSOD. Say take for 1 week you have started in this low dose. Then you will start building up this dose. After 1 week, you will do tablet, amitriptyline, 25 mg HSOD. Okay, so this how you introduce amitriptyline. You start with low dose and then you come on to actual dose that is 25 mg. And generally, what we have seen that all patients who are having TTS, they respond very good with triptans. They respond very good to amitriptyline. So, okay, if you have get any call from your relative, your attendant, or anyone, sir, I am having this kind of problem, and you are thinking that this is the problem TTS, take proper headache history and start with like initially PCM 1000 mg, 500 mg. You can give SOS, then start with amitriptyline. Initially, start with a low dose that is your 10 mg HSOD per week, and then start building up the dose. Now we will come to the most important topic that many of you are want to know, that is migraine. So, any of you know any patient of migraine? Because if you are knowing any patient of migraine, na, you know what kind of symptoms they face in day-to-day life. And sometimes, na, because I am not having migraine, is suppose anyone of you are not having migraine, so you don't know the harsh reality in which they live, and when their headache occurs, how they feel. So, if anyone who knows his nearby, his relative who is having migraine, anyone? Because he or she must be knowing about the symptoms of migraine also. Okay, no worry. We will start with migraine. So, first thing, it is a repeated headache of 4 to 72 hours with normal examination. That is, the neurological examination is normal and no nala beruzgar. What causes? Are you asking about TTH causes or migraine causes? Now, bache, these headaches are primary headaches, so though they don't have any cause, they have a stressor factor. They have a stress. Suppose there is any patient who, when goes in traffic, he gets his migraine headache. They have stress factor. They are not having any cause. Migraine, TTS, they themselves are a primary cause. Na, they are not any secondary cause. If suppose you are getting headache due to meningitis, then secondary headache cause have a meningitis as a cause. But primary headache doesn't have any cause. They have a stress factor. Okay, now we'll start. And no other reasonable causes. Now, so remember, migraine headache episode will be between 4 to 72 hours. That is for sure. If they are not taking any treatment or any tablet, okay, 4 to 72 hours of duration. And peak time of headache. Peak of headache will occur on first day. On first day. And most common after 90 minutes of headache. So what this means? Now, After this my class now, whenever will you see any headache patient, you have to draw this graph. You have to draw this graph like this. Okay. Here is your maximum intensity. Maximum intensity. And here is your time duration. Take it between 0, 60 minutes, then around 120 minutes, and then a whole day. Okay. Now, this migraine headache will be like this. Start, and peak around this 90 minutes. And after that, it will continue for more than one day. So you have to draw this graph for any kind of headache because in uh, in now onwards we will study other type of headache. This is TAC. This is trigeminal autonomic cephalgia. In those headaches, peak comes around between 0 to 15 minutes. So by this graph, you will able to differentiate between other types of headache. That is a trigeminal autonomic cephalgia or migraine. So migraine headache will start with 0 minute. It will go on increase, and it will peak around 90 minutes, and then will continue lower, and it will continue till 2 or 3 days. So everyone has understood this graph, how to draw this graph by taking history. Anyone who has not understood, then please tell me. I will again repeat because this graph making is very much important. Because when we used to sit in our neuro OPDs, we always used to draw this kind of graph because this graph not only help you but also help other doctor who is seeing that patient after your. So anyone who has problem with this graph, tell me. Everyone is okay? Shall we proceed further? Okay. So I guess there is no one who has any problem in understanding this graph. So we will proceed further. Now, your migraine patient should have at least two of the following. What is that? That is your uni unilateral pain. So in migraine, pain will always be unilateral. But but generally, what we study patient doesn't come like this. So there's one day I was sitting in my neuro OPD. Initial days, a patient come with me. He was saying that, yeah, sir, मेरे को तो bilateral pain हो रहा है. And I was thinking that in this paper has written this is migraine. तो I was thinking यार migraine कैसे हो गया? तो bilateral pain हो रहा है. इसको TTH लिखना चाहिए था हमें. हमने migraine क्यों लिखा? क्या हमने को गलती तो नहीं कर दी? But later on when I discussed this with my senior, so what I get to know that migraine is unilateral, but in later on period in your life, this unilateral will progress to bilateral. Okay, so what does it mean? That initially migraine pain will be unilateral. Suppose today I have got my first symptom of migraine as a headache. It will be unilateral. But later when I will progress about 1 year later, 2 year later, it will convert into bilateral. But there is interesting thing in this. अगर पेन bilateral भी है, but फिर भी पेन एक साइड ही ज्यादा होगा, that is unilateral. Okay, so if migraine pain from unilateral has converted into bilateral, but still migraine pain will be more in one side. As contrast to TTH, in TTH, pain will always be bilateral, but it will be equal intensity in both the headache. It will be not like कि one side ज़्यादा है कि second side कम है. But in migraine, pain will always unilateral. If it's from unilateral, it has progressed to bilateral also, but it will always be more on one side. So everyone understood this thing that कि भाई migraine का pain bilateral भी हो सकता है later on life में. But कैसे distinguish करेंगे कि कभी कभी भी हमेशा वो एक साइड यूनिटर थोड़ा ज्यादा ही होगा एज कम टू टीटीएच में वो बायलेटरल होगा दोनों तरफ बराबर होगा सो एनीवन हैविंग एनी प्रॉब्लम इन दिस कंसेप्ट so I guess everyone has understood this point now so this is the most important point you should understand whenever you taking history now it comes second is your throbbing pain so what do you mean by throbbing pain that is your pulsatile pain now थ्रोबिंग पेन का मतलब क्या है पेशेंट हमारे पास आएगा हिस्ट्री में क्या हाउ टू आस्क हिस्ट्री फॉर थ्रोबिंग पेन पल्सटाइल पेन यू विल आस्क पेशेंट कि जो हेडेक है, सिर में दर्द है, वो ऐसे आता है क्या? धक धक आता है। क्या आता है? धक धक आता है। तो यू विल आस्क दिस इन हिस्ट्री बिकॉज इट इज अ पल्सर टाइप. So what you will ask in history? Is it a throbbing pain, pulsatile, या जो दर्द है वैसे धक धक करके आता है? So, have you understood this point? Throbbing on pulsatile type, धक धक. Third is intensity of pain. No, migraine pain will be always will be a moderate to severe intensity. And fourth and last is that is it is aggravated by movement. Means जब भी तुम कोई माइग्रेन का पेशेंट है, जैसे देर व्हेन आई वाज डूइंग जीआरसी, देयर वाज माय फ्रेंड who has this migraine as a headache symptom. So he was always like, यार भाई तू जा, मुझे बेड पे लेटे दे. तो that what this mean that these patients generally when you ask history na, so they will say, sir, when we lie down on the bed, our headache pain decreases. So because this pain is aggravated by movement, so it is unilateral pain, can convert into bilateral. It is throbbing, in धक धक करता है, moderate to severe intensity means कभी भी ये mild नहीं होगा, and it is always aggravated by movement. After this thing, at least two of things, then comes at least one of the following. So I am adding plus between. So what are these at least one of the following? That is your nausea and vomiting. And second is your photophobia and phonophobia. Up, this is the most classical symptom you will get in every, not in every, but maximum headache patient. I guess around 83-84% of migraine patient will be having this symptom. That is your photophobia and phonophobia. So when you will ask them ना, फर्स्ट की पेन एक तरफ होता है, वो बोलेगा हाँ एक तरफ होता है, या कोई बोलेगा कि भाई नहीं सर बायलेटरल होता है. ओके, आगे चलते हैं. देन आस्क धक धक होता है, बोले हाँ सर धक धक होता है. देन यू आस्क कि जब हेडेक होता है, क्या सारी लाइट बंद करने का मन करता है, क्या सबको ये मन बोलने का मन करता है कि बस सब चुप हो जाओ? सो यू विल आस्क देम कि इज योर पेन डिक्रीजेस व्हेन यू स्विच ऑफ ऑल द लाइट्स एंड व्हेन यू टेल एवरीवन टू बी क्वाइट इन योर रूम. So the most classical symptom there. Because what I was saying that when I was doing GR na, my junior residency, so there was this patient, my friend, which has migraine. Na. So whenever he get episode, what he used to do, he always used to switch off the light. And every music system he used to switch off. So this is the most classical symptom. Any of your friend is suffering from migraine, he will be having this photophobia and phonophobia. So any one of you who are suffering from migraine and ever in your life experienced this photophobia and phonophobia, because you usually have experienced this kind of pain, no? Photophobia and phonophobia feature. Anyone? Everyone understood how to take migraine history and what to ask in history? Unilateral, throbbing, intensity, aggravation by movement, nausea, vomiting, photophobia, and phonophobia. So start with the diagnostic criteria of migraine. Re- Repeated attacks of headache lasting 4 to 72 hours in a patient with a normal physical examination, no other reasonable cause for the headache, and at least two of the following, that is unilateral pain, throbbing pain aggravated by movement, moderate or severe intensity, and at least one of the following, that is your nausea, vomiting, and photophobia and phonophobia. Okay, so now I think you have understood the concept of migraine. Now you will never miss any patient of migraine whenever you are sitting in your OPD or anything. Now, there is a one also the most classical symptom in migraine patient, that is your osmophobia, and it is very classically seen in migraine patient. So, what do you mean osmophobia? That these, just like photophobia and phonophobia, these patients get irritated when there is an unpleasant smell around them. Okay, now we will come to symptoms. Now, what are the most common symptoms? That is your nausea, which encounters about 87%. And the most classical and which will get in history, that is your photophobia. That is around 82%. Then is your lightheadedness around 72%. Then vomiting 56%. With there is visual disturbance, there is paresthesia, there is vertigo also, diarrhea, syncope, seizure, and in 4%. Now we will discuss about this pancreas stone patient in our abdominal pain class. Right now, here we are focusing only on your our headache. Okay, change in mindset. So in 4% of patient, you can also have a confusional state also. This thing you should always remember. Now, now we will come to what kind of migraine stress are there. So there's always not trigger factor in migraine. So what we find that if you are in a crowded place, if you are in traffic, or if there's hot climate is there, or if there are any hot and spicy food. So there can be many kind of stress factor, and it depends on individual to individual. So for knowing stress factor, you have to take a proper history. Like someone can be there that if I go outside in this place, I am getting migraine attack. If or I am in traffic, I am getting headache, or if there is very cold climate, I am getting headache. So for every individual, stress factor can be different. But how to know stress factor? You have to take a proper history, because if you eliminate this stress factor, now automatically chances of or frequency of migraine in that patient will automatically will decrease. Now comes a classification of migraine. So migraine is of two types. First is your that is your migraine without aura. That is seen in 7 to 80% of patients. That is known as common migraine. And second is your migraine with aura. That is seen in 20 to 30%. And that is your classical migraine. And aura is visual, then sensory, and then motor. So all of you know about what is aura. Any of you, if you are not knowing about aura, I will describe what is aura. Anyone? All of you know aura. What is aura? So tell me in comment section what is aura. It means everyone knows about aura. So I will tell you what is aura. So before headache, sometimes what we have seen that some patient of migraine have aura. So what is aura? Aura is something like any any conception. Suppose you are seeing thing but normally don't see. Suppose like in migraine, you most common type of aura is your visual aura, in which you see a flashes of light around your eye. So you are perceiving something which initially doesn't exist. Suppose you are getting any sensory aura, something is running on your hand, something is your burning sensation in your hand, or any kind of motor or visual aura. So something which initially doesn't exist, but now it is existing and you are preconcepting it. It is known as aura. And classically it is seen in classic migraine, which is migraine with aura. And in migraine with aura, this headache episodes precedes aura. Oh, sorry, headache episode occur after your aura. So there will be aura, which something will be you are seeing something that initially doesn't exist. And after that you will get a headache episode. Something kind of hallucination, but hallucination are something different. They are they are like just something other. This is a psychiatric problem. Aura lasts for around 2 to 3 minutes, or sometimes can last 1 hour. But in aura, you are concepting something which is initially don't exist. You can say it is like hallucination, but hallucination is a disorder itself. Na? So that's why we are not counting it as a hallucination. Now, when we come to classification of migraine, what we are seeing that there is migraine without aura and migraine with aura. Okay. Then comes your migraine with typical aura, that is typical aura with headache and typical aura without headache. Okay. So there are some migraine in which there is aura, but that is without headache also. You have to also know this. Then comes migraine with brainstem aura. Then comes your hemiplegic migraine. What happens in hemiplegic migraine? Patient will come you in casualty or OPD having hemiparesis at that side, and you will think, oh, it is hemiplegia. But that hemiparesis or hemiplegia one side will subsequently be okay in 1 hour. Okay, so this we call as a hemiplegic migraine. Now there are some disorders like familial hemiplegic migraine. What are all of these? These are family hemiplegic migraine type 1, type 2, type and 3. So there is generally one MCQ generally asked, and that is which channel is defected in this familial hemiplegia. That is your mutation is in voltage gated calcium channel. So I repeat, in familial hemiplegic migraine, there is mutation in voltage gated calcium channel. Then comes your sporadic hemiplegic migraine, retinal migraine. There is something known as chronic migraine. Uh, Actually, Arya, FMGs can also watch this. It is not about cracking any exam like FMG, NEET PG. It is only about that clearing your concepts and how you can handle these kinds of patient in your OPD and emergency. Because our ultimate goal is not cracking any exam. Na? You have to crack FMG or NEET PG. Our ultimate goal is to treat the patient. And we are studying to treat patient. We are not studying to crack any exam. Exam is just a part of life. We have to give and we have to move further, but our main goal is to treat patient. If at MBBS you are treating patient good, that is fine. Sometimes we have found that we have done PG and still we are not able to treat patient. So it is not about cracking exam. We have to study to treat the patient. And if we study according to it, how to treat the patient, exam we will be cracking automatically. Many times you see na, because after reading theory doesn't anything happen. If you want to be a good doctor and you have to be good in knowledge, you have to see a lot of patients. Because I am also studying headache from a lot of time. In UG, I have studied headache. In my PG, also I have studied headache. But my knowledge in headache or my knowledge in migraine, it increased after when I went to GB Pant for my neuro postings. Na? Because at that time, we are seeing lot of headaches. Okay. So your main concern is from now is that after this lecture of 1 or 2 hours of headache, you should be able to treat any kind of headache patient, or you should be able to give a primary management to any headache patient you then encounter in your life further. Now comes the complication of migraine. That is your status migrainous. It means migraine episode lasting more than 72 hours. Then is your persistent aura without infarction, migrainous infarction, migraine aura triggered seizure. Then is probable migraine, that is probable migraine without aura and with aura. Then comes your episodic symptom. Now, now we will come to what is your chronic migraine. So at least 15 days a month headache, and out of these 15 days, 8 days headache should be like migraine type, and for at least 3 months. Now, when you will see any paper of any neurologist who is labeling any patient as chronic migraine, we have many times we see that this patient is a chronic migraine. So when we see a patient is a chronic migraine, well, in 1 month, he or she is getting 15 episodes of headache. And out of that 15 episode, 8 episodes of headache should be like migraine one. And this thing should be happen for at least 3 months. Then we will label the patient as a chronic migraine. Now we will come to stages of migraine. How migraine happens. Now how patient will come to us in OPD and tell us history, and how all things of migraine start. So there is four things. First is your prodrome. Second is your aura. And I have told you, tell me which kind of aura is most common in migraine. Is it visual, sensory, or motor? Because this is your FMG question always. Which kind of aura is more common in migraine? Is it visual, it is motor, or it is sensory? Tell me in comment section. Third is your headache phase. Any one of you, which is the most common aura in migraine? Is it visual, sensory, or motor? Tell me. And after headache is your visual. Very good. It is your visual aura that is most common. And in visual, it is zigzag lines you see, that is the most common. Very good, Arya. Okay, so now all of you are understanding how to treat migraine, how to see the migraine patient, how the stages are there. And fourth phase is your postdrome phase. So migraine has four stages. One is your prodrome, second is your aura, third is your headache phase, and fourth is your postdrome phase. So starting with prodrome phase. So what we see in prodrome? Prodrome is generally we are experiencing fatigue, irritability, yawning, thirst, and neck pain. This is your prodrome. After the prodrome, it comes second is your aura, and it is seen in 20% of patient of migraine. Now, classical things about aura is that it resolves in 60 minutes, and it is followed by headache. So aura lasts more max to max about 60 minutes. Okay. Then comes there is a one term that is known as acephalgic migraine. That is aura without migraine. Now, types of aura. You all know that most common is your visual. And in visual, that is your most common is your zigzag lines. Then your scotoma. Then is your flashes of light. So I was telling about, my roommate when I was in junior residency. So he used to get the flashes of light before the headache migraine episode. He was like that something is bright is coming in his eyes. So these kinds of aura you can get to know when you take a proper history of migraine patient. After visual, there are some language aura in which expressive, paraphasia, and dysphasia are seen. Okay. After the second stage of aura, third is your headache phase. In this, what will you see? You will see unilateral, moderate to severe pain, and pain is like dhak dhak. What do you mean by dhak dhak? It is throbbing or pulsating, like your heartbeat ना. You ask this history to patient कि यार जो दर्द होता है वो ऐसे होता है क्या धक धक. He will say हाँ सर ऐसे होता है. This is your throbbing and pulsating type of headache. associated with nausea and vomiting. And then comes your last phase, that is your post-drome phase. And post-drome phase, it, in post-drome phase, na, your maximum features are same as prodrome phase. So, four stages of migraine are there. Prodrome, in which fatigue, irritability, yawning, and thirst will be there. Then you will experience aura. In most commonly your visual, you will experience flashes of light. Then will occur your headache phase, which lasts between 4 to 72 hours. Okay. It peaks on first day of headache itself. Matlab, if you're getting headache today, it will be maximum today only. And it generally peaks around 90 minutes. That I have told you previously. Then after when headache will subside, then comes your postdome phase, in which features are same like that your prodrome, that is your fatigue, irritability. Now, after understanding stages, we will also know a short point on what is pathogenesis of migraine. Because if we are giving treatment, we should know what is the pathogenesis and what you are targeting to treat the patient. Now, first is your most important is your vascular theory. Now, in vascular theory, it is your first is your intracerebral blood vessel constriction, which causes aura. So, if we have to stop aura, what kinds of drug we should will give? We will give blood vessel vasodilators. Okay, are you understanding? Aura is due to blood vessel constriction. So to overcome this, what we have to give? We have to give blood vessels dilator. And headache is due to blood vessel dilation. So to overcome headache, what will you give? You will give vasoconstrictor like triptans. Triptans you give for headache because they will act as a vasoconstrictor. But for aura, what will you give? You will give beta blocker like propranolol because they will act as a vasodilator. So that is the importance of knowing pathogenesis to give best treatment and to you should know what you are taking. If you are taking aura or you are taking headache. If you are taking headache, you have to give drugs which act as a vasoconstrictor because headache is due to vasodilation. And if you are taking aura, you have to give drugs which are vasodilator because aura is due to vasoconstriction. So you should be clear cut knowing. So everyone, are you knowing what is aura and what is headache? Headache is due to vasodilation and aura is due to vasoconstriction. That is the most important thing of pathogenesis. So please tell me in the comment section. Are you okay with it that headache is due to vasodilation or is due to vasoconstriction? Okay, Harshita is asking when patient has both, sir. Matlab, you are saying aura headache both. No, patient will have aura, then he will have a headache. Patient will have aura, then headache is there. Because in stages, I have told you, na, कि aura will be there. It resolves in 60 minutes, followed by headache. So initially aura is there, then headache will occur. Aura and headache never occur simultaneously. So first there is aura, then is headache. And aura is due to vasoconstriction, headache is due to vasodilation. I think Harshita, I think you have got your answer. Now, other thing in pathogenesis, that is your activation of abnormal brain activity. Now, what we have seen that there is some abnormal there is some abnormal brain activity that can be due to some environment or genetic. Okay, it will trigger brain. And earlier we have studied that all the pain sensitive structures who carry their nerve supply. Now tell me, all of which cranial nerves carry the brain supply of all the pain sensitive structure? It is first, second, third, fourth, fifth. Which cranial nerve carry all the sensation of brain sensitive structure for headache? Tell me. I have told you in my first slide. Anyone who can tell me which cranial nerves carry all the sensation of pain related sensitive structures in head? It is first cranial nerve, second cranial nerve, third, fourth, or fifth cranial nerve, or sixth cranial nerve. Anyone? It is headache. Fifth. It is fifth cranial nerve which carries the sensation of all the good Arya. It is fifth cranial nerve. So fifth cranial nerve with all this pain sensitive structure is known as TVS. That is your trigeminal vascular system. So pain sensitive structure, that is your dura and vessels, plus your trigeminal nerve is known as trigeminal vascular system. And this activation of your trigeminal vascular system causes your pain. Now we will see this diagram. Now this is a very beautiful diagram given in Harrison about pathophysiology of headache. Now see with me. These are your meningeal vessels. Okay, these are your meningeal vessels. These are in your dura. Are you seeing dura? Yes, sir, we are seeing dura. These meningeal vessels in dura are your pain sensitive structure. When they are stimulated, they go to your trigeminal nerve. That is your trigeminal ganglion. This trigeminal ganglion will end its second order neuron in TCC. What is TCC? TCC is your trigeminal cervical complex. Okay. When they end in TCC, it will lead to activations of cells in trigeminal nucleus. What it will lead? It will lead to activation of cells in trigeminal nucleus. Now, when this cells in trigeminal nucleus is activated, they release some vasoreactive substances. That is your VIP, nitric oxide, and CGR. So what there is? There is some vasoreactive substances, that is your VIP, NO, and CGRP. And right now, all our doctors and current treatment new modalities are coming in migraine to stop these vasoreactive substances. And the most important vasoreactive substances is your CGRP. So there are many drugs right now coming in the market which are antagonists of this CGRP vasoactive substance, because this is the vasoactive substance which irritate and lead to further pain. So we have to stop this CGRP. So now new modalities are coming which act against this CGRP. Now these neurons then will project into the quantothalamic tract after decussating in the brainstem. So from TCC, the further neuron will arise. They will go to your thalamus. They will go to your thalamus. And by which tract? This is your quantothalamic tract. Okay. And this will go to your sensory cortex and you will experience pain. So we have understood pathophysiology. What are the two important things we have to take in from pathophysiology? Is that your aura and headache. Aura is due to vasoconstriction, headache is due to vasodilation. There are some vasoreactive substances like VIP, NO, and CGRP, which are produced when there is activation of your trigeminal nucleus, which leads to pain. Now, now comes most important thing, that is your history of migraine and headache. Now, you know all things about migraine. You know about stages. You know about diagnostic criteria. You know about pathogenesis. You know everything. Now patient comes to you in OPD. Patient is not like that. हाँ सर मेरे को migraine है बताओ मुझे medicine दो. Patient ऐसे नहीं आएगा कि मेरे को migraine है. You have to take proper history of patient. So whenever any headache patient is coming to you, what you will ask first? You will ask laterality. मतलब what do you mean by laterality? कि भाई पेन यूनिलेटरल है या बायलेटरल है, यूनिलेटरल है या बायलेटरल है, और अगर बायलेटरल है तो क्या पहले यूनिलेटरल था और फिर बायलेटरल में कन्वर्ट हो गया, और अगर बायलेटरल है तो क्या किसी एक तरफ ज्यादा पेन होता है, दैट यू मीन बाय लेटरलिटी. सेकंड, ड्यूरेशन ऑफ हेडेक, दैट इज योर ड्यूरेशन ऑफ हेडेक. अगर माइग्रेन का पेन है और कोई मेडिसिन नहीं ली तो पेन विल लास्ट अराउंड 4 to 72 hours. सो if pain is of migraine, it will always last from 4 to 72 hours. And symptoms, पेन कैसा है, थ्रोबिंग है, ओके, क्या, if is it coming nausea and vomiting? So you will ask history like this: letality, duration, symptom, and after adding all this factor, you will conclude to one factor: is it migraine or is TTH, or which kind of primary headache is there? So whenever now we used to sit in our neuro OPD, so that is my when I was in GV. So this is most important thing we used to say, that there is something called a headache diary. So suppose patient is coming to you and he is telling you history, but sometimes patient doesn't tell proper history and proper thing. Na? So after prescribing any NSAIDs to patient, so suppose patient is coming to me first time for uh, headache. Now I'm bit confused. कि यार ये TTH है, migraine है, क्या है? So what I will do? I will prescribe him tablet PCM 1000 mg SOS कि भाई तू ये पैरासीटामोल की टैबलेट लेना जब तेरे को हेडेक, और तू मेरे पास 3 से 4 दिन बाद आना, और एक हेडेक डायरी बनाने को बोलना। क्या बोलना है? हेडेक डायरी। यू हैव टू टेल पेशेंट टू मेंटेन अ हेडेक डायरी, एंड यू विल टेल पेशेंट कि whenever you will come next time, you have to come with this headache diary. This is the most important thing to know: is it migraine, is it TTH, what was it? So what all are things in headache diary? First is your date, then comes headache hours कि भाई हेडेक था पर कितने घंटों के लिए था, 2 घंटा, 3 घंटा, 4 घंटा, 6 घंटा, कितने घंटों के लिए? Then comes severity, because we all know that migraine pain is always moderate to severe. Then comes your nausea and vomiting. Then comes your photophobia and phonophobia. Then you will ask the aggravation with activity. भाई कोई क्या स्ट्रेस फैक्टर है? क्राउड है, ट्रैफिक है, कोल्ड क्लाइमेट है, खाना है, क्या है? इज इट थ्रोबिंग, धड़कने वाली दर्द? क्या धड़कता है? जैसे दिल धड़कता है, क्या ऐसे दिमाग भी धड़कता है? क्योंकि दिल धड़के तो चलेगा पर दिमाग धड़के तो नहीं चलेगा. सो इफ इज इट इज थ्रोबिंग और व्हाट काइंड ऑफ पेन, एंड इज इट यूनिलेटरल और बायलेटरल? देन कम्स एक्यूट ड्रग, मीन ड्रग से रिलीव्ड हो रहा है नहीं हो रहा. एसओएस में जो आपने जो ड्रग दिया, सपोज यू हैव गिवन पैरासिटामोल, इज दैट ड्रग इज एबल टू लिव पेशेंट पेन और नॉट? सो every one of you now with me will say that every patient of a headache you will come to you will prescribe him any NSAID, and then you will tell that patient to maintain a headache diary. Everyone have understood the meaning and importance of headache diary? Then give me a thumbs up if you know what is the importance of your headache diary. That is your date, hours, severity, nausea, vomiting, photophobia, phonophobia, aggravation with acute throbbing pain, unilateral bilateral acute. Everyone good to go. So if now onwards, if any patient coming to you to first time with headache symptom, you will tell him कि भाई अभी diagnosis नहीं करेंगे. First, you will give him any drug so that if headache pain is there, that pain will subside. So any kind of NSAID or naproxen tablet you will give, and then you will tell him कि भाई this is your headache diary. These all are the things in this headache diary. You have to maintain this for 3 to 7 days, and come with us to with this headache diary. Okay, everyone. Because there is a difference between a good doctor and a better doctor. है ना? That's a concept of a good doctor. He will always tell a headache diary. So, okay, good Harshita, good Arya. Now, if you have understood the importance of headache diary. Now, after understanding the importance of headache diary, now we know everything. We know stages. We know everything. We have told patient to maintain his headache diary, and patient is coming near after 7 days. And after 7 days, after calculating all the symptoms, I am thinking that it is migraine. So, how to handle migraine? अब मेरे पास डॉक्टर्स की कॉल आते हैं, इंटर्न्स की कॉल आते हैं, अदर डॉक्टर्स को आते हैं, क्या सर पेशेंट को माइग्रेन है, शुड वी स्टार्ट द ट्रीटमेंट? सो when to start the treatment? If that patient is getting more than 2 episodes per month. Then you think of starting the treatment. And before starting treatment now, because you have taken a proper history. So first ask patient about stressors, and you have to remove the stressor, because just by removing the stressor, maximum thing will be okay. You don't have to give drugs if the stressors are subside. So you ask the patient proper history and tell patient to avoid this any kind of stressor. Now, after avoiding any kind of stressor, now first thing is your non-pharmacological therapy. Okay, first is your non-pharmacological therapy. What you will tell? You will tell patient to avoid smoking, avoid any kind of alcohol, any triggers or stressor factors, and sleep. You will tell patient you have to take sleep at all the same time. So a proper sleep cycle should be maintained. Okay. Now, pro- patient comes to you. You have tell avoid smoking, avoid alcohol triggers, and proper sleep cycle. Then what generally when I was in GB Pandin, I was doing my neuro posting. What generally we used to prescribe? We used to prescribe them any relaxation therapy, yoga, and that CBT, and any stress management, any stress management thing, daily exercise. So this all is your non-pharmacological therapy. First, you have to start patient with the non-pharmacological therapy. That is, avoid any kind of smoking, alcohol, triggers, sleep, any kind of stress. Then we will move on to your our relaxation therapy part. That is your yoga, CBT, stress management, and that is your daily exercise. Now we'll come to pharmacological therapy. Okay. Now in pharmacological therapy, first is your abortive therapy. सो व्हाट डज यू मीन बाय अबॉर्टिव थेरेपी? भाई पेशेंट को हेडेक हो गया, फटाफट ऐसी मेडिसिन देनी है जिससे पेशेंट का हेडेक दूर हो जाए. ओके, वी हैव टू स्टॉप हेडेक एज क्विकली एज पॉसिबल, सो यू हैव टू गिव हिम अबॉर्टिव थेरेपी. एंड what generally we used to prescribe is that in abortive therapy comes your NSAIDs and come your naproxen. So किसी पेशेंट को हेडेक है, माइग्रेन का, अबॉर्टिव थेरेपी में क्या दोगे आप? फर्स्ट टैबलेट PCM 1000 mg, not 500 mg, 1000 mg SOS, or you will prescribe tablet naproxen, that is your 550 mg SOS. Okay, so everyone have understood abortive therapy, that is the NSAIDs, naproxen, tablet PCM 1000 mg SOS. Then will come your tablet naproxen, that is 550 mg SOS. अब कोई भी हेडेक माइग्रेन का पेन होगा तो हमें अबॉर्टिव थेरेपी सबके लिए पता है हमें क्या करना है, या तो पैरासीटामोल 1000 mg देनी है, या नेप्रोक्सिन 550 mg SOS. देन shall we go further? Give me thumbs up if you are comfortable with this abortive therapy, and we will go further. So we are going further now. Now suppose you have given patient PCM and naproxen. but still patient pain is not reducing. Okay, so you have to have you now you have to add a further drug. Now which drug you will give after you have given PCM naproxen? Then comes your, if patient is having moderate to severe attack, you will give him triptans. What do you use? Triptan. And triptans are vasoconstrictor because headache is due to vasodilation. So you will give him triptan, which are vasoconstrictor, which act as vasoconstrictor. So what kinds of triptans you will give? First is your alitriptan. That is your 40 to 80 mg. Then comes your rizatriptan. That is your 5 mg or 10 mg. So, and this is the most effective drug, na? Rizat. So generally, I always remember a patient comes to me. I was prescribing him naproxen 2 or 3 times, 550 mg SOS, na? But still patient pain was not subsiding. So what I give? I give tablet Rizet 5 mg SOS. Okay, if you this is the best medication you can prescribe any migraine patient. Sudden give you when you prescribe, after few minutes patient pain will subside. So what is it? Tablet Rizet 5 mg SOS. Now suppose patient is having a severe pain or a very severe migraine. So then you have to give something IV. So what we generally give? We give a Suma triptan 6 mg subcutaneous injection. Okay. Sumatriptan 6 mg subcutaneous injection. When you have to give, when patient is having severe or very severe pain of migraine and patient is on casualty, you can repeat the dose in 1 hour. Add maximum 2 doses in 24 hours. You can give. And remember that triptans act through 5-HT1B and 1D agonists. And what they do? They do vasoconstriction. So, in whom they are contraindicated? They are contraindicated in patients having CVA, CAD, pregnancy, and any vascular problem. Okay. So, triptans act through 5-HT1B, 1D agonist. They what they do? They do vasoconstriction. So, whenever in your OPD you are prescribing triptans to any patient, you will ask कि कोई कार्डिक हिस्ट्री तो नहीं है, कोई कभी कोई स्ट्रोक तो नहीं आया, प्रेग्नेंट तो नहीं हो, डीवीटी तो नहीं है, CVA, CAD, pregnancy, vascular problem. You have to rule out this. So everyone now know the contraindication of triptans because in pharma you must be studying about contraindication of triptans. So if you know contraindication of triptans, now give me a thumbs up. Everyone, triptans are vasoconstrictor. They are contraindicated in CVA, CAD, pregnancy, and any kind of vascular problem. Okay. Now, other than triptans, there are also one drug that is your dietans. They act through this 5-HT1F agonist. And which drug is in their dietans? This is your lasmiditan. Okay, so So PCM, naproxen, your triptan, that is your rizatriptan, that is the best drug, tablet, Rizac 5 mg SOS or 10 mg SOS. If very much severe condition there, you can give sumatriptan, 6 mg subcutaneous injection. You can repeat the dose. Triptans act by 5-HT1, 1B, 1D agonists. They are powerful vasoconstrictor, so they are contraindicated in CVA, CAD, pregnancy, and vesical problem. Dietins, other drug, they act through 5-HT1 agonist. Now, now suppose you have given abortive treatment to patient. Now, pain is not there, but you have to prevent any subsequent episode. Now, we all know that there is aura. After that, so Harshita is asking me if we can't give this क्या नाम है triptans if they are content indicated, which drugs we can give. Good question. No, so I will tell you if triptans are contraindicated. So what we have seen that migraine is a condition which there is excess of dopamine is there. So we give dopamine blocker, D2 blocker we can give. That is your prochloroperazine and domperidone. Okay. So this D2 blocker you can prescribe if you are not able to prescribe triptans to patient. Okay. Shall you go further? And with D2 there are some ergot drugs, ergotamines. So if you can't prescribe triptans, you can give D2 blocker or you can give ergotamine drugs. Now, patient comes to you with, he's saying, yeah, sir, pain अब नहीं हो रहा, pain subside हो गया. So you have to prevent now further episode of migraine. For what that will you give? You will give a medication which will act as a vasodilator because you know that aura is due to vasoconstriction. And after aura, what happens? Headache happens. So if you are able to stop this aura, headache will not happen. So aura is due to vasoconstriction. So you will give vasodilator. Okay. So there are four drugs in prophylactic therapy. That is your beta blocker, then is your CCB, then is your antidepressants, and then is your anticonvulsant. So beta blocker, CCP, antidepressant, and fourth is your anticonvulsant. So these four drugs you can prescribe in prophylactic therapy. So starting with beta blocker. One of the most common drugs generally we prescribe to any migraine patient, that is your beta blocker. So in beta blocker, the most common used drug is your propranolol, and dose is your from 80 to 240 mg per day. And how we prescribe? We prescribe like this: tablet, propranolol, 40 mg BD. Okay. So patient is coming to me, a migraine patient. What treatment I will give him? I will give him treatment tablet, naproxen, 550 mg SOS, and tablet propranolol 40 mg BD. This is for abortive therapy and this is for prophylaxis. So generally we give this to them. So everyone, now you can manage migraine patient or not? Give me thumbs up. Now are you having confidence in managing migraine patient? Everyone. Because now you also know abortive therapy and prophylactic therapy. So now will you be able to manage now any patient of migraine in your life? Give me thumbs up. Okay. Now Now, before starting propranolol, that is your beta blocker, na, there are some contraindication of beta blocker. We have to think, we have to take that all in consideration. That is your asthma, that is your asthma, COPD. If patient is having any brady, okay, patient is of hypertension. And most important thing, whenever you are sitting in neuro OPD and you have to know beta blocker contraindication is your depression. So what I have seen, Janina, because we all remember all the contraindication of beta blocker, that is your asthma, COPD, bradycardia, hypertension, but we forget depression. So you have to ask this history. Are you asking, can we give beta blocker in pregnancy, Harshita? So right now there is no such any contraindication of prescribing beta blocker in pregnancy. You can give it. Right now there is no any such contraindication that you can't give beta blocker in pregnancy. Okay. Only contraindication are your asthma, COPD, brady, hypertension, and most important is your depression. And I will say, whenever you think, yeah, कि ये drug pregnancy में दे सकते हैं नहीं दे सकते, if you have any much confusion, because there are some confusion ना कि भाई ये drug pregnancy में दे सकते नहीं दे सकते, always see which category does it belong, because there are A, B, C, X categories, and some categories that you can't give. So you go Google it out which this drug belongs to which category, or it can be given in pregnancy or not. Okay. Now, after beta blocker, we will move to calcium channel blocker, that is your CCB. In CCB, the most common is your verapamil, that can be given from 80 to 160 mg per day. Then comes your flunarizine. Okay. Third is your antidepressant. In antidepressant, you can give amitriptyline. And you all know that amitriptyline is a drug of choice for TTH also. So there are some patients which have TTH migraine both, and some are having underlying TTH on migraine also. So amitriptyline is good for them also. So amitriptyline you can give in TTH, you can give in migraine also. Last is your anticonvulsant. In anticonvulsant, there is a valproic acid, there is topiramate. Okay. So these all are your prophylactic drugs. First for your beta blocker propranolol, then comes your CCB, then comes antidepressant, then comes anticonvulsant like valproic acid and topiramate. Now you will ask me, yes sir, हमें पता चल गया कि we have to give prophylaxis, but we are having lot of options. We are having propranolol, and suppose patient is having bradycardia, you can't give propranolol. So there are propranolol, calcium channel blocker, there are antidepressant like amitriptyline, there is your topiramate. So how do we know that which prophylactic drug is best suitable for which kind of person? So starting. So I will start first with topiramate. Na? If you have to give topiramate to any patient, so you all know that topiramate topiramate has a side effect of weight loss. Okay. So if there is any lady coming to your OPD, he's obese and he want to lose his weight or her weight also. So what you will prescribe? You will prescribe him her topiramate. Okay. But before prescribing to any patient topiramate, you have to do two things. First, you have to get a USG done for any kind of renal stone, and you have to refer her to ophthalmology for glaucoma. So after ruling out glaucoma and renal stone, you can prescribe the patient topiramate for if is obese patient. Now, amitriptyline. You will start with initially 10 mg HS40 for 1 week, then you will increase dose to 25 mg. Now, suppose there is a patient coming to you. He is saying, "Sir, headache hota hai, but रात को नींद नहीं आती." So what you will give? You prescribe him amitriptyline because amitriptyline has a side effect of drowsiness. Okay. So now are you now all are you comfortable with prophylactic drug? You are knowing which drug to prescribe well. Topiramate when a fat and obese woman is coming. Amitriptyline when patient is having disorder in sleep. And if problem if patient is not able to confirm on beta blocker, antidepressant, topiramate, you can then prescribe him valproate also. So these four kinds of prophylactic drugs are there, and you can play with them according to the patient situation. If the patient is obese, you can give him topiramate. If patient is having sleep issue, you can give him amitriptyline like this. Now we will come to new treatment option in migraine. So I already told you in pathogenesis that there is some CGRP vasoreactive substance, and there are new modalities are coming to stop this CGRP. So this new treatment is against your CGRP. That it is your calcitonin gene related peptide. So this treatment is against CGRP. So there are two kinds of drugs in CGRP. First is your oral CGRP antagonist. That is your Geptans. What are these? These are Geptans. And this CGRP agonist antagonist, this is the most important MCQ right now as in any kind of FMG NEET PG paper. So this is the most very much important topic. CGRP, na? So Geptans. In this they are Remy, Gepant. Okay. Then comes your monoclonal antibodies. And that is your Eptinezumab. And it can be given IV also. So you are knowing a new treatment that is against CGRP. That is your oral, that is your Geptans, and then it is your monoclonal antibodies like Eptinezumab. Now, except these, there are other treatment options also. That is like your greater occipital nerve block. Another is your onobotulinum toxin A. So these are other kinds of management. See, if you will see na, onobotulinum toxin type A is now given in chronic migraine patient. This is your MC. Okay. Right now, botulinum toxin is prescribed in chronic migraine patient. So we have completed right now migraine. Na? So after completing migraine, we will see how to approach migraine patient in OPD. So if patient is coming to you in OPD, how will you approach this patient now? So patient is coming to you in OPD. First, you will take a proper history. You will tell to him for headache diary. And after confirmation of migraine, you will start on him with tablet PCM or naproxen. If still headache is there or pain is more severe, you will give him tablet Risect 5 mg. For prophylaxis, you can give beta blocker amitriptyline, beta blocker like tablet, propranolol, that is 40 mg BD, you can start. Now we will come to some exciting topic, that is your menstrual migraine. So what is the menstrual migraine? Migraine which worsen during cycle. Okay. So any migraine. So suppose this female patient is coming to you and she is telling you कि sir माइग्रेन के एपिसोड अराउंड पीरियड्स के जब पेन होता है तब बढ़ जाते हैं. सो माइग्रेन वर्सन ड्यूरिंग साइकिल, दैट इज योर मेंस्ट्रुअल माइग्रेन. एंड व्हाट इज द ट्रीटमेंट? ट्रीटमेंट इज सेम एज योर गिविंग योर माइग्रेन पेशेंट, but near the cycle days you have to give him NSAIDs and naproxen also tablet, so that pain severity of pain should be decreased. Other is of migraine in pregnancy. Now, what we have seen that 70% of remission or improvement is during pregnancy. What we mean by this? That maximum time migraine episode decreases in pregnancy. And if you are getting migraine episode in pregnancy, it will be migraine with aura. Okay. And you will see management is same like you management a normal migraine. So after completing migraine, we will come to most interesting topic, that is your trigeminal autonomic cephalgia. Now, how this trigeminal autonomic cephalgia differs from migraine is the most important. So, starting with clinical features. So, it is short lasting. It is short lasting. Means duration is less than 4 hours. But you know that migraine pain lasts from 4 to 72 hours. It is short lasting. That is less than 4 hours. And it is always associated with autonomic dysfunction. Now you will say कि सर क्या माइग्रेन पेशेंट में ऑटोनॉमिक डिस्फंक्शन नहीं होता? होता है, बट माइग्रेन में 50% पॉपुलेशन में ऑटोनॉमिक डिस्फंक्शन होगा. बट इन ट्राइजेमिनल ऑटोनॉमिक सिफेल्जिया, ट्राइजेमिनल ऑटोनॉमिक सिफेल्जिया बिकॉज स्टार्ट विद नेम ट्राइजेमिनल means pain is happening in distribution of trigeminal nerve, that is your 5-1, because we all know that trigeminal has three distribution, that is 5-1, 5-2 and 5-3. So pain happens in trigeminal distribution, that is your 5-1. Other is autonomic. What is mean? It means it always will have an autonomic dysfunction. Third is your cephalgia. So what mean by cepha? Cepha means your cranium part, and algia means pain. So pain with autonomic symptoms, and that also in trigeminal distribution, that is 5-1, is known as trigeminal autonomic cephalgia. So everyone have understood what do you mean by the name trigeminal autonomic cephalgia? Then give me a thumbs up. Everyone who have understood that what do you mean by trigeminal autonomic cephalgia? Because the name tells everything. Give me a thumbs up, then I will proceed further. If you know what do you mean by trigeminal autonomic cephalgia. So short lasting, which is less than 4 hours, always associated with autonomic dysfunction, and always unilateral, and multiple episodes per day. So I have said always unilateral. So there is a characteristic distinction between a migraine patient and TAC patient. I will tell you that TAC is unilateral and it is side locked. So now you ask, sir, what do you mean by side locked? Now, migraine is also unilateral, but migraine is not side locked. Suppose I am having migraine pain. Uh, Suppose this month my pain is for on right side. 2 or 3 months later, pain can be on left side. So pain is changing, unilaterality changing in migraine. But in trigeminal autonomous failure, pain will always be on right side. That's why it is unilateral side locked. So you have to write this in that case sheet or answer sheet or your history taking sheet that the pain is unilateral and that also is side locked. So now understanding what do you mean by side lock? Everyone understood? Because migraine pain is not side load, it is unilateral. It can be on right side also, it can be on left side also. But if tag pain is there and if it is happening right side, then it always be on right side. That's why it is side locked, unilateral side locked, and multiple episodes per day. Now you are seeing this diagram of fifth nerve. You are seeing this ophthalmic nerve 5-1. This is the distribution of trigeminal autonomous phalangeal pain. So pain happens in this area. That is your orbit and frontoorbital area. This is the pain of trigeminal autophagy area, this area. So short lasting, less than 4 hours, always associated with autonomic dysfunction and multiple episodes per day and unilateral and side long. Now, four diseases come under this heading of trigeminal autonomous failure. That are is your cluster headache. Second is your paroxysmal hemicrania. Third is your SUNCT or SUNA. And fourth is your hemicrania continua. Now, many of you will tell me ना right on conversation कि सर हमने तो कभी पेशेंट ट्राइजेमिनल ऑटोसल्जी का देखा ही नहीं है. हमने तो माइग्रेन हेडेक के पेशेंट देखने हैं. वी हैवन एवर डायग्नोज कि कोई क्लस्टर हेडेक का पेशेंट है. इफ देयर इज पैरोक्सिस्मल हेमिकेनिया पेशेंट और सुना पेशेंट. सो टेल मी इन कमेंट सेक्शन, any one of you have ever seen the patient of trigeminal autonomic cephalgia ever in your life? Anyone? Have you ever seen patient of trigeminal autonomic cephalgia in your life? Then tell me in the comment section. I guess no one have ever seen. Na? So now will you see? Because you know the diagnosis. Short lasting will be less than 4 hours, always associated with autonomic dysfunction. Haha. So that's I have said. No one you have ever seen. Na? But I have seen various cases when I was having neuropost. So one more thing. I have said that always associated with autonomic dysfunction. So what are the symptoms of autonomic dysfunction? That is your redness in eye. That is your lacrimation and fear from eye. So what are the autonomic dysfunction symptoms? That is your redness. That is your lacrimation in eye, lacrimation and tearing from eye. Now we will proceed further. Now, now this is a beautiful table which is given in Harrison about differentiating these three types of headache. So I will zoom it further. Na? Starting with cluster headache. It is more common in males than female. It is stabbing, boring kind of pain that is in your orbit and temple region. It lasts from 15 to 180 minutes. Lasts from 15 to 180 minutes and 1 to 8 episodes per day. 1 to 8 episodes per day. And alcohol trigger is there. Alcohol trigger is there. Comparing to paroxysmal hemicrania, female is to male is ratio equal. It is also throbbing in boring time, but it lasts from 2 to 30 minutes and frequency is 1 to 20. So what we are saying that as duration of attack, as duration of attack is decreasing, frequency is increasing. See, in cluster headache, duration of headache is 50 to 180 minutes. So frequency is 1 to 8 days. But in paroxysmal hemicrania, duration is decreasing 2 to 30 minutes. So frequency of headache is increasing. That is 1 to 20 headaches per day. That is greater than 5 headache per day. And when we come to SUNCT or SUNA, here headache is lasting duration is only 5 to 240 seconds. 5 to 240 seconds. So in a per day, you are getting 3 to 200 episodes. In a per day, you are getting 3 to 200 episodes. So just draw diagram with me. That is your SUNCT and SUNA. Then comes your paroxysmal hemicrania. Then comes your cluster headache. Okay. As we go above, what increase? Frequency is increasing. And as we go below, duration of headache will increase. Okay. Now we'll remember this diagram. SUNCT paroxysmal cluster. As duration of headache, मतलब पीरियड कितने पीरियड में वो हेडेक हो रहा है, लास्ट कर रहा है, अगर वो डिक्रीज करता है तो फ्रीक्वेंसी बढ़ेगी. So as frequency increases, duration of headache increases, or as duration of headache is increasing, the frequency, the number of times that headache is occurring in that particular day, it will decrease. So now we will start with our first headache. That is our cluster headache, also known as suicide headache. Okay, 5 attacks should be there for diagnosis. Generally seen in more male than female, and that also young male. Most severe headache you will ever see in your life. It is unilateral and non-throbbing. So I remember this case when I was intern and I was in my casualty and I was having ortho posting I was having. Na? So this is a patient who was initially sitting on bed and suddenly a headache episode was come and he was running like anything. Matlab, you will see whenever you see the patient of cluster headache, na, they will be running in pain because so much pain is there. Na, patient can't bear that pain. That's why it has given a name of suicide headache. So much. It is like na there is a bore and you're drilling in that bore. Such severe pain is there in cluster headache. So whenever you will see patient of cluster headache and they are having a headache episode, they will be running like anything because pain is so much severe. It is like suicide headache pain. It is stabbing and excruciating pain in periorbital region. Patient is restless with pain. 1 to 8 attacks per day and duration 15 minutes to 3 hours. associated with autonomic features, and alcohol is a trigger factor. So this is the criteria of cluster headache. At least five attacks, severe or very severe unital headache. So tell me the most important point of cluster headache which you are taking from this lecture. That is a very, very severe headache. Most severe headache is of cluster headache. So tell me in comment section the most important point about cluster headache, that is severity of headache. Everyone comment what kind of pain is there in cluster headache, and at least one of the following symptom of sign, that also an ipsilater, that is your conjunctival injection or lacrimation, nasal congestion or rhinorrhea, eyelid edema, forehead and facial swelling, stabbing and very severe kind of pain. Good, Harshita. Sensation of fullness in the ear and meiosis and ptosis, and a sense of restlessness. So what I've told that when I was seeing that patient, initially he or she was sitting in that casualty. So when episode occurred, he was running like anything. So whenever there is a episode of headache in cluster headache patient will be running. He will be a sense of restlessness will be there. So now comes to treatment of cluster headache. So for acute attack, treatment is 100% oxygen, 10 to 20 minutes, and that is 12 to 15 liters per minute. Or you can give subcutaneous sumatriptan, that is 6 mg. So this question obviously asked many times asked that what is the treatment of cluster headache? That is 100% oxygen for 10 to 20 minutes, and that is 12 to 15 liter per minute. 12 to 15 liter per minute, or subcutaneous sumatriptan. And in question, they will give you option 100% oxygen, 10 to 20 minutes, 5 to 8 liter, or 10 to 12 liter, or 12 to 15 liter. You have to mark that answer is 12 to 15 liter. So tell me in the comment section how much oxygen per liter should you give. That is your 12 to 15 liter per minute. Of this much oxygen you have to give. Then comes your prevention part, or you can say prophylaxis part. So in prophylaxis, you have to give CCB. That is your verapamil. And what is the dose? It is generally around, you can give around 160 to 960 mg per day. And what generally I used to prescribe in my OPDs is that I give tablet verapamil 80 mg TDS. So that come on near about dose about 240. This is the treatment for prophylaxis. For acute, you can give subcutaneous sumatriptan or 100% oxygen, 12 to 15 liters per. Now, in short, I will tell you difference between migraine and TAC patient. First, duration greater than 4 hours, and TAC is always less than 4 hours. Migraine becomes better on lying down. Contrast to TAC, in which patient is having restlessness. It is unilateral, but it is unilateral and side-locked. Means always will occur at that side only. Okay. And in cluster headache, now there is one or two more important thing about cluster headache. I will tell you. That is, its name is written cluster headache. Means this headache comes in cluster. Means suppose there is a duration of 12 months duration there. So this will come in for 2 or 3 months. Headache will come and then will go away. So this headache come in clusters. Okay. Suppose there is a patient, he is having headache in June and July. So headache will occur in June and July, and after that there will be no headache. But whenever headache episode will be there, it will always be clusters. So that's why name is given cluster headache. It will always occur in clusters in a particular duration, and then headache will subside. Then there will be a headache free period for a long time. Then there will be a headache free period for a long time. That's why we have given his name the cluster headache. Now we will come to other headache. That is your second is your paroxysmal hemicrania. And how it differs from cluster is duration of headache is less than cluster. First thing. So if duration is less, then frequency automatically will increase. So duration, it is around 2 minutes to 30 minutes. And frequency is around 5 to 20 episodes per day. It will be unilateral plus autonomic symptoms. Now, you will say, sir, suppose patient frequency is 10 episodes. You can get 10 episodes in cluster headache also. And patient duration is suppose sir 30 minutes. You can get 30 minutes in cluster headache also. Then how will you differentiate between cluster and paroxysmal hemicrania? Because pain also will be in the paroxysmal hemicrania. But cluster headache pain is severe. But you can't differentiate on pain basis. So what we use, if you are giving treatment for cluster headache and suppose patient is not getting relief, then you will start him on give him trial of paroxysmal hemicrania trial. And what you give in this? We give indomethacin. What we give? We give indomethacin 25 mg TID for 3 days. So if initially you have given a treatment of cluster headache, your patient is not getting relief. But now you have given him treatment of indomethacin. So the patient of paroxysmal hemicrania responds to indomethacin. So by response to indomethacin, you can get to know that yeah, this pain was of paroxysmal hemicrania. So Harshita, here we will cover migraine, we will cover trigeminal autonomic cephalgia, and one or two causes of secondary headache. Then we will end our lecture. Okay. So every one of you, tell me the drug of choice for paroxysmal hemicrania. This is the most important question you get. Every one of you in comment section, tell me the drug of choice for paroxysmal hemicrania. Yeah, yeah, Harshita, we are just on ending phase. Uh, Actually, Harshita, this is a Harrison-based series. So after headache, we will come next to fever because if you go on Harrison, we are covering Harrison topic by topic. So after this, we will move on to fever with rash, paralysis of unknown origin. Now, We are covering all headache topics in this lecture. Only few headache topics are left. We will cover that also. Now comes the third one. That is your SUNCT and SUNA. So we will start with their name itself. That is short lasting unilateral neuralgia headache attacks with conjunctival injection and tearing. Okay. So by name we are seeing that it is a short lasting unilateral headache attacks with conjunctival injection and tearing is there. So what are the more important points? Is that it has a cutaneous trigger. So by touch, if suppose that patient is sitting in your OPD of SUNCT and SUNA and you touch that patient on cheek, patient will get headache because it has a cutaneous trigger. But alcohol trigger are absent. Okay, so patient is having cutaneous trigger, alcohol trigger are absent. More common in males than females. What is the duration? It is around 5 to 240 seconds. And attacks, they are around 2 to 600 attacks per day. Okay, so short lasting cutaneous trigger. Or even on touch, you are having pain. Alcohol trigger is absent, more in males compared to female. Duration is 5 to 240 seconds. Attack frequency is around 2 to 16 attacks per day. And for treatment, we are giving IV lidocaine. Okay. So we have finished SUNCT and SUNA. Now comes fourth. That is your hemicrania continua. So in this, a background headache is always there. Is always there. Especially it occurs in elderly females. Okay. There are autonomic symptoms and it responds to indomethacin. Now, so they will continuous background kind of headache, and this background headache is always unilateral with migraine features. So patient in background is always having a unilateral migraine kind of feature, and whenever pain is there, he will be experiencing autonomic symptoms. Okay, that is your hemicrania continua. After that, we will come to a important topic that is trigeminal neuralgia. Because trigeminal neuralgia also has a cutaneous trigger like SUNCT and SUNA. But there is some difference between SUNCT and SUNA and trigeminal neuralgia. Because SUNCT and SUNA was a part of trigeminal autonomic cephalgia. That's why SUNCT and SUNA was having autonomic features. But trigeminal neuralgia is not a part of SUNCT and SUNA. Oh, sorry, trigeminal autonomic cephalgia. It is not a part of TAC. That is your trigeminal autonomic cephalgia. That's why trigeminal neuralgia is not having autonomic symptoms. So we first have to understand that trigeminal neuralgia is something different from TAC. TAC is trigeminal autonomic cephalgia. In that, three or four terms are coming. That is your cluster headache, paroxysmal hemicrania, hemicrania continua, and SUNCT. And trigeminal neuralgia is totally different thing. But trigeminal neuralgia pain is also like SUNCT because it is having cutaneous trigger. But autonomic symptoms are absent in trigeminal neuralgia patient. So pararog paroxysms of intense stabbing pain, which is unilateral, shock-like. We all know that Salman Khan suffered from this trigeminal neuralgia, and it is in V2 and V3 distribution because trigeminal autonomous neuralgia in V1 distribution. It is in V2, V3. This is your V2 and V3 distribution. You are seeing in this distribution there is trigeminal pain is there, and it is intense superficial pain which lasts for few seconds to minutes, and there are cutaneous triggers. So, any one of you in ever life you have seen the patient of trigeminal neuralgia? I will tell you how the patient will come. There is a shock-like pain, like some have given you electric shock in your cheek area. Okay, now these patients have a cutaneous trigger. So, but there was one day I was sitting in OPD, a patient comes to me with trigeminal neuralgia patient. So when patient was crossing me, a blow of air was coming from some side from fan. That fan blowing of air which comes and hitting his cheek, that also acts as a trigger many times. So patient experience pain while washing their face, while someone touch their face, or by uh, air from fan, any kind of cutaneous trigger. And pain is so severe, so stabbing, and it comes like intense. Okay, so intense superficial pain is there, which lasts only for few seconds to minutes. It is also a cutaneous trigger, so you have to think it from SUNCT. But in SUNCT, autonomic symptoms are absent. So all on me, all tell me in comment section what is the difference between SUNCT and SUNA and trigeminal neuralgia. Please tell me what is the most important distinguishing factor between trigeminal neuralgia and SUNCT and SUNA patients. All of you, tell me in comment section, please. Some students are like, sir, हमने तो कभी trigeminal neuralgia patient ही नहीं देखा. So हो सकता है it is quite okay if you don't have seen the patient. But if you are knowing proper history, some day will come you will see the patient. Don't take that in consideration. You will see the patient in your life because all of your life is pending now right now. Tell me what is the most important distinguishing factor between trigeminal neuralgia and SUNCT and SUNA in comment section. No one. It is autonomic symptoms. In SUNCT and SUNA is a part of trigeminal autonomic cephalgia. So they are having autonomic symptoms. Trigeminal neuralgia is not a part of trigeminal autonomic cephalgia. So autonomic symptoms are absent in trigeminal neuralgia patient. What is the treatment? Treatment is carbamazepine, or you can give lamotrigine. So Mashur, I was saying I was having one side headache after doing MRI was normal, but still. So M- Mashroor, you should first create your headache diary. Okay. And then after headache diary, we will meet 3 to 7 days after. Then we will get to know what kind of pain you are having. Okay, Mashur? Because the most important thing in any kind of headache is your headache diary. So, Mashur, are you diagnosed with any kind of headache? Then tell us also about that. So, Harshita is like, even I have headaches daily with neck stiffness. So, Harshita, what kind of headache you are having? Are you having bilateral or unilateral? Because first we have to move on. No, no, Harshita, I'm asking that, are you having headache bilateral or unilateral? So then we will, and what kind of stress factors you are having? So all the students now, Harshita will be maintaining his unilateral headache. Okay, is it like throbbing or pulsatile? धक धक करता है headache, जैसे दिल करता है, धक धक. So I took PCM unilateral right side. Harshita, is your headache throbbing or not? Tell us about. Yes, Harshita, can you tell your headache is throbbing or not? So you are not having throbbing kind of headache. Okay. So it is unilateral is there. You are taking PCM, and after PCM, is your headache is getting relieved or not? So now you will create your headache diary for 3 or 7 days. Okay, Harshita? And we will meet in our, okay, from 2 years you are having na. So now you will be maintaining a headache diary with you. And we will meet in next class after 3 to 7 days. Then you you will be sharing me your headache diary. And we will discuss what kind of headache you can be there. Okay. And, or is there photophobia is there or not in Harshita? हाँ ओके हर्षिता. तो मेंटेन योर हेडेक डायरी. तो मशहूर अली वाज लाइक स्टैबिंग पेन है सर मॉर्निंग में बहुत कम होता है आफ्टरनून से फिर इंक्रीज होता है persistently टेम्पोरल रीजन का पेन है आफ्टर पीसीएम यूजुअली गोस ओके. So all of you who are telling me you about your headache, please first you maintain your headache diary with you. Okay, after this headache diary, you just you all of you can WhatsApp me your headache diary. I will be sharing my number you in this comment section. All of you just maintain a headache diary of 3 to 7 days. You WhatsApp me your headache diary with your audio symptom. Then we will come to conclusion and we will start a treatment with you. Okay, okay, Harshit and Mashura, I will be sharing my number to all of you in my WhatsApp section. Okay, shall you go further? Okay. Right now we have to finish our class also, na? Just maintain your headache diary for 3 to 7 days and WhatsApp me your headache diary. Then we will proceed further. Now we will do some MCQs, na? Now starting with this, a 34-year-old patient presented to us with recurrent episodes of headache, which is localized to the right forehead. Means it is localized to one side. Okay. Recurrent episodes are there. The pain was of stabbing type and very severe. The patient had about 12 to 15 episodes of pain every day, with each episode lasting for about, yeah, yeah, Mashur, I will sharing my WhatsApp number with all of you. With each episode lasting for about half an hour. Okay. So pain is lasting about less than half an hour. So it is less than 30 minutes. So it is not migraine. That is confirmed. Because migraine pain is always greater than 4 hours. First thing, okay. The headache was associated with redness and watering of the right eye. It means autonomic symptoms are there. Which of the following is used for treatment? They are asking. So patient is having about 12 to 15 episodes of pain every day. What does it mean? Patient is having episode 12 to 15. It is like paroxysmal hemicrania type of it. Because in cluster, its frequency is not that much. So it is paroxysmal hemicrania. And what is the treatment of paroxysmal hemicrania? It is indomethacin. Okay. Now we'll come to other question. A 38-year-old man came and complaining of recurrent attacks of severe headache for the past 30 minutes. He has been doing this every day at the same time for 1 week, and the episode lasts for about an hour. He had a history of severe left side excruciating episodic headache. Most episodes are accompanied by rhinorrhea. There are no cutaneous triggers. It does not respond to indomethacin, and attacks get triggered by alcohol. What is this headache? So, any one of you will tell it does not respond to indomethacin. What does this mean? That it is not paroxysmal hemicrania. Attacks are triggered by alcohol, not by cutaneous touch. An episode of headache lasts less than 30 minutes, so it is not migraine. So, what kind of trigeminal autonomic cephalgia headache will it is there? Can anyone tell me in comment section? Mashur, Harshita, Priyanka, can you tell me which kind of trigeminal autonomic cephalgia pain is this? It is not migraine because it is not lasting for more than 4 hours. It is not paroxysmal hemicrania because it is not responding to indomethacin. Attacks are triggered by alcohol. So, can anyone tell me which kind of trigeminal autonomic cephalgia is this? Anyone in comment section? Mashroor, Harshita, Arya Nag, anyone? Very good. It is cluster headache. Why not SUNCT and SUNA? Because SUNCT and SUNA doesn't have alcohol trigger. It has cutaneous trigger. Very good. Now comes to last question. A 40-year-old male is diagnosed to have SUNCT. It can be distinguished from trigeminal neuralgia by the presence of all except. So, patient having SUNCT and SUNA, it can be yes, yes, Archie, that is good now because uh, SUNCT and SUNA have a cutaneous trigger, not alcohol trigger. Now, how will distinguish between SUNCT, SUNA, and trigeminal neuralgia? A 40-year-old male is diagnosed with SUNCT. It can be distinguished from trigeminal neuralgia by the presence of all except excessive lacrimation, nasal congestion, conjunctival injection, and short attack of stabbing pain. Now, all of these ABC are मशहूर सेइंग दैट क्लस्टर में रेडनेस और वाटरी आई है क्या बेटा ट्राइजेमिनल ऑटोनोमिक सेफेलिज्म के अंदर जितने भी पेन आते हैं चाहे वो क्लस्टर है चाहे वो पैरोक्सिमल हेमिकेनिया है चाहे वो सुंकटन सुना है चाहे वो हेमिकेनिया है सब में आपको ये ऑटोनोमिक सिम्टम्स तो मिलेंगे मिलेंगे डिस्ट्रीब्यूट करने का तरीका ही क्या है कि जो हमारा सुंकटन सुना है उसमें अल्कोहल ट्रिगर नहीं होता उसमें क्यूटिनस ट्रिगर होता है तो ये इंपॉर्टेंट पॉइंट है और जब हम क्लस्टर से सुंक सुना की तरफ तक जाते हैं तो क्लस्टर का ड्यूरेशन ज्यादा होता है फ्रीक्वेंसी कम होती है सुंक सुना के अंदर ड्यूरेशन कम होता है फ्रीक्वेंसी बढ़ती है ओके और जो आपका पैरोक्सिमल हेमिकेनिया वाला पेन है वो इंडोमेट्रोसिन का रिस्पॉन्स करता है क्लस्टर हेडेक 100% ऑक्सीजन एट 12 to 15 लीटर को रिस्पॉन्ड करता है सो दीज ऑल आर द डिस्ट्रीब्यूशन फीचर्स बिटवीन ऑल दिस टाइप ऑफ हेडेक नाउ सो these all are autonomic features and these autonomic features will not be present in trigeminal neuralgia patient. These are present in TAC patient. So, because I have told you previously, to distinguish between SUNCT and SUNA and trigeminal neuralgia, important thing is your autonomic features. Now, before ending our session, we will take in some secondary headache causes. And we will start with meningitis. So, everyone in this comment section, tell me the triad of meningitis. Start. Tell me the triad of meningitis. And Harshita, you will tell me triad of oh, triad of meningitis. Harshita, anyone triad of meningitis? How meningitis patient present to us? Fever, neck stiffness, neck rigidity. Good, because Harshita is saying neck stiffness. That's why I've asked Harshita. Good, Sadhudi. Fever, neck stiffness, and headache. And also very good. Altered mental status. So meningitis patient headache is secondary headache. Because now these are the ways ना you will remember something. Because suppose I am having neck stiffness, so this is the common way ना जिससे हम याद रख सकते हैं भाई फीवर नेक स्टिफनेस हेडेक मेरे को नेक स्टिफनेस भी है हेडेक भी है अगर फीवर हो जाए या आर्टिमेंटल स्टेटस हो जाए तो इट विल बी कन्वर्टेड टू meningitis. हाँ या you are not having fever. Then comes your temporal arteritis pain. No. Nausea is not. Nausea is not. Nausea, vomiting are not of part of meningitis. Now we'll come to temporal arteritis. So before understanding temporal arteritis pain, na, we will see what is the distribution of superficial temporal artery. So you are seeing this diagram. So just forward to your ear lobule, you have this superficial temporal artery. Okay, and these are your frontal branch of superficial temporal artery. So just go this your ear, just forward to this your superficial temporal artery. You can palpate this, and then here are these branches of frontal branch of superficial temporal artery is there. So in temporal arteritis, what we found that there is thickening. You are seeing this granular nodular pattern. So there is thickening of this frontal branch of superficial temporal artery is there. So female, more than male, 50 and older, ASR greater than 50, form temporal artery, jaw claudication pain, flu-like illness and fever. So I always remember of one case when this was the first case which I have diagnosed as a temporal arteritis. So patient come to me, he was like, sir, headache हो रहा है, unilateral headache हो रहा है, and this in temporal region. So I said, okay. So I was taking all his history. When I palpate here and I see here, there is something as swelling kind of I found. So I see here, so here is some granular nodular pattern is there. So what I have prescribed him. So you can do two things. Either you can take biopsy of artery, because you all know that temporal arteritis pain is in giant cell arteritis. Or other thing you can do is you can do ultrasound. Ultrasound. On ultrasound, you found halo sign. What you found? Halo sign. Okay. And you have to prescribe this patient a prednisolone course. What is treatment? It is prednisolone. Why? Because if you don't give treatment, this patient will can end into a blindness. So you have to give prednisolone as quickly as possible. And so you do USG. In USG, you will found a halo sign will be there. What sign? Halo sign. So everyone in comment section, tell me which finding of temporal arteritis you will found in USG. You will found a halo sign. Okay, and you will always start this patient on steroid as quickly as possible to avoid chances of blindness. ठीक है, अगली बार से कोई भी टेम्पल आर्टराइटिस का पेशेंट आएगा, ऐसा पेशेंट जिसको स्वेलिंग है टेम्पल आर्टराइटिस में, आप पाल्पेट कर रहे हो, आपको स्वेलिंग लग रही है, पेशेंट यूलेटरल हेडेक बता रहा है, फीमेल है, पेन बता रही है, जो क्लॉडिकेशन बता रही है, तो जल्द से जल्द स्टीरॉइड में इसको स्टार्ट करना है, वरना उसको ब्लाइंडनेस हो सकती है. ओके, सो व्हाट इज द ट्रीटमेंट ऑफ टेम्पोरल आर्टराइटिस? टेल मी इन कमेंट सेक्शन. Any one of you? Treatment for temporal arthritis. Steroids. And why you have to give steroids very as quickly as possible to prevent which disease? Why you have to give steroids? Why you have to give steroids to patient to temporal arteritis to prevent which thing? Tell me in comment section which thing you have to prevent. For that, you have to give steroids as quickly as possible. Blindness. Very good. Now comes this patient, glaucoma. So this is a very good incident, I will tell you. So this is a time of around 9 p.m. And generally my emergency duty when I was in first year, it ends around 9 p.m. Now, and this patient was referred to us from ophthalm also. The patient was referred to us from, sir, सर मेल्स में नहीं होता क्या? बेटा ये टेम्पोरल अर्थराइटिस किस में होता है? जॉइंट सेल अर्थराइटिस में होता है। और जितनी भी आपकी रूमेटोलॉजिकल डिसऑर्डर्स है या ऑटो इन्फ्लेमेटरी जितनी भी आपके डिसऑर्डर्स है, ये फीमेल्स में मोर कॉमन होता है एज कम्पेयर टू मेल्स। ओके, मेल्स में भी होता है बट बहुत रेयर। ऑल ऑटोइम्यून कंडीशन, ऑल रूमेटोलॉजिकल कंडीशन आर मोर कॉमन इन फीमेल्स एज कम्पेयर टू मेल्स। एंड मेल्स में भी मिल जाती है, ऐसा नहीं बेटा नहीं मिलती। जब आप पेशेंट देखोगे, व्हेन यू विल सिट इन क्लिनिक यू विल फाउंड एनी एवरी काइंड ऑफ पेशेंट। हाँ, सो 9 p.m. this patient lent to me. So this patient was having a severe unilateral headache on one side. Okay. So when I was taking history, he was like, sir, acute headache हुआ है। पहले में एकदम सही था। Patient की age was around 60 to 70 years age वो patient was there. So when I was doing examination, so one side redness थी। So initially I was thinking that यार कहीं ये कोई ट्राइजेमिनल ऑटोनमिक स्पेल्जिया का पेशेंट तो नहीं है, इसको आई में रेडनेस वगैरह पड़ी है। बट ही वाज लाइक, सर पहले कभी ऐसा हेडेक नहीं हुआ, अभी हुआ। सो व्हेन आई वाज एग्जामिनिंग व्हाट आई फाइंड दैट देयर इज redness and on the side of pupil you will find that pupil is mid dilated pupil, mid dilated pupil. So patient comes to you with an emergency with severe headache with mid dilated pupil with redness. It is glaucoma unless proven otherwise. It is glaucoma. High intraocular pressure, blood vision is there, head pain is there, lacrimation is there, redness of eye is there. So what I have done, immediately I started patient on mannitol and patient responded. Because what mannitol will do? Treatment is mannitol. What mannitol will do? Mannitol will decrease intraocular pressure. So tell me everyone, how glaucoma patient with headache will present to you? It will present to you with redness and mid dilated pupil. Redness, mid dilated pupil. Tell me everyone in comment section how glaucoma patient will present to you. Redness with mid dilated pupil. Tell me in comment section everyone. It's not about redness. What is the most important thing? Redness you will find in trigeminal autonomic cephalgia patient also. Mid dilated pupil. You have to remember that. Redness with mid dilated pupil patient will present to you. Yeah, very good, Priyanka. So now, now we are ending our discussion. So what all we are taking from this lecture is that when patient will come to us, when patient will come to us, we will first ask a proper history. Okay. Then we will ask red flag signs. What are red flag signs? Like a boyfriend or girlfriend are having कि भाई इसको बॉयफ्रेंड नहीं बनाना, ये रेड फ्लैग बॉय है। इसको गर्लफ्रेंड नहीं बनाना, ये रेड फ्लैग गर्ल है। So everyone of you remember what are red flag signs? Can anyone of you tell me any red flag sign? So red flag signs are very much important in our life ना, कि भाई रेड फ्लैग है बंदे को दूर भागो, है कोई और बंदा पटाएंगे, इसको नहीं पटाएंगे, इसमें रेड फ्लैग है। So red flag signs will help us to distinguish between primary headache and secondary headache. Okay. So you will first ask all red flag signs कि भाई प्राइमरी हेडेक को सेकेंडरी हेडेक में डिफरेंशिएट कर पाए, क्योंकि इफ रेड फ्लैग साइंस आर देयर देन इट इज सेकेंडरी हेडेक. अगर लड़के में रेड फ्लैग साइन है, क्या है भाई, सेकेंडरी है, लड़का छोड़ो भागो यहाँ से. ऐसे अगर रेड फ्लैग साइन प्रेजेंट है तो ये इट इज सेकेंडरी हेडेक. सो रेड फ्लैग साइन, यस और नो. इफ यस, it is secondary headache. If no, it is primary headache. After coming to secondary headache, we will do further investigation. Either it can be a glaucoma or it can be a temporal arteritis. And remember, all patients who are having headache, they must should undergo a ophthalmic examination always. All patients of headache must undergo ophthalmic examination. Okay, so tell me in comment section which is the most important thing you will do. A patient will when will patient of headache will come in your OPD, you will do ophthalmic examination. What examination you will do? Tell me in comment section. All if any patient of headache is coming in your OPD, tell me everyone which examination you will do if any patient of headache is coming in your OPD. You will do ophthalmic examination. You will send patient for eye examination. Any patient of headache is coming in your OPD. Okay. And if it is primary headache, then you will prescribe him NSAIDs or naproxen. And then you will tell patient to maintain a headache diary. Then you will tell the patient to maintain a headache diary. After that, patient will visit you after 7 days, and you will analyze his or her headache diary, and then you will make the diagnosis. Okay. So any one of you, if you are having any question headache, just tell me, because we are only 1 or 2 minutes are left in my session. Any question related to headache? Have you understood the whole lecture? Because after this lecture, you will be seeing numerous patient headache, and now you will be able to handle every patient headache. Okay. So if any question is there, just tell me in comment section related to headache. Anyone? Any question related to headache is there? Tell me just. Okay. Shall we complete our this class? So here we now we are. Thank you. We are ending this lecture of headache. I think all of you have liked this lecture, and all of you now will be some better in your knowledge of your headache. And now will be seeing some patient headache. You will be able to handle them. Our next lecture will be on fever, fever with paroxysmal unknown origin, and we will see how to manage patients with fever, fever with rash, fever with unknown origin in our OPD, so that we can become a better doctor. Okay. Goodbye. Thank you. Good night.